introduce myself, and then I'm going to pass it over for Chris to introduce herself. And then we have a lot to discuss today. And just as a reminder for anybody who has joined before now, feel free to type in the chat where you're joining us from. We like to see where people are coming in from all across the state and the West, it looks like. And as a reminder, we will have breakout rooms and activities. So make sure you're paying attention and keeping your mind learning while you're eating or whatever else you have going on right now around you. So my name is Dr. Ashley Yager. I am with Utah State University Extension, and I serve Carbon and Emery counties in my health and wellness faculty role. And in this role, my primary objective is to focus on the opioid overdose crisis that our state has been facing, and particularly Carbon and Emery counties, since that's my location. I have a primary focus on that region. And my background actually is in clinical psychology. So when I come to the lens of looking at substance use disorder and opioids and talking about everything that we're talking about today, I bring that perspective and that person-focused perspective, but also talking about all the things that go into substance use disorder and recognizing that it's not just one thing that is causal or one person to blame. And so my Master's of Science and PhD are both in clinical psychology. I had several years of clinical work where I saw people from a generalist perspective, and my psychological therapy really was collaborative and client-centered and focused on that biopsychosocial aspect of people. So thinking about biology, psychology, and their social support systems and all of that. So that's in a nutshell who I am. And I am so pleased to be here with all of you. And I know most of you are social workers, and I reminisce very fondly on my days of clinical work with my multidisciplinary social work team and miss my team. So that was a really fun team that I got to work with. But I'm going to pass it to Chris to let her introduce herself as well.
Yeah, thanks, Ashley. And it's so good to see so many names. I don't get to see faces yet, but maybe eventually you'll, turn on your video and so I can see your faces. But it's good to see your names of so many people I know. And there's a lot of people I don't know, so welcome. So my name is Chris Meyer. I'm an assistant professor in the social work department. I'm in my 5th year at USU. And also interestingly, I spend a majority of my time at USU working for Extension. So I'm what's considered a specialist. I have this long title, the Community Resource and Economic Development Specialist, which means absolutely nothing. What it means to social workers is I get to do community practice every single day in my role as a faculty at USU. So it's a really special position to be in. So I work a lot with Ashley. I work a lot in the Southeast Health District area. I work a lot in the Uintas. I tend to work completely in more in rural communities than urban, working on a variety of issues. My preference is nutrition, but I do a lot with substance use prevention and those kind of things. So as a social worker, many years ago, it's been a long time since I got my MSW from the University of Iowa, but I actually was a play therapist. So I spent my years in clinical practice doing that with families in the DCFS system. I worked with their parents as well. And I was highly dissatisfied as far as the direct clinical practice. I just felt like my families were working so hard and they just never were able to improve their situations. And that's why I went into community practice. So I really respect and applaud everyone who's hanging in there with the clinical practice. You're doing such an important job. I just really struggled in play therapy long-term because my family's just really continued to just be stuck in the DCFS system in Iowa. And so I've gone on and I do a lot of program evaluation. And then, like I said, I'm currently just doing community practice across the state of Utah and rural communities. So really excited to have you today, and hopefully you'll learn something about some of the programs also going on in Utah related to opioid stigma reduction. And we're going to be using some stuff from some grants that we have actively going on. So enjoy.
Yes. And we actually wanted to get a poll for the very first thing that we do and ask you, do you work directly with clients who use or are in recovery from opioids, and that should have popped up on your screen. And feel free to, it's yes or no. We wanted to get a gauge of your interest and of the people here who works with people in recovery or with clients who are using opioids, since that's going to be our primary focus.
Just we'll leave it open for another few seconds. Most people have participated, Ashley.
Mm-hmm.
So
yeah, and if I end it, we'll let it show. Yeah, share. Okay. So now you can see the results that, 3/4 of the people here today said yes, they're working in people in recovery or people who are using opioids. Thank you for sharing that. And 1/4 of people said no, and that's okay too. We're glad to have everybody here. And I think a lot of this information will still be applicable to the 25% of people that said no, because maybe you're coming to see what it's all about. And our second poll, do you work with clients who are indirectly impacted by opioids? This means they do not use or are not in recovery, but have family or friends that use or are in recovery. And I'm seeing on my end, we're just going to leave it open for just a second longer in case somebody hasn't had a chance to respond. But almost 100%, I'm going to go ahead and end it. I think everybody's had a chance that yes, almost everyone they work with has been impacted in some way or another by opioids. And that's us. Right. And just take a second to let that sink in. Like almost 100% of us, even in our personal lives, could say yes to that question as well. Okay. So we're going to talk about substance use disorders generally, just to get us started. And then we're going to focus more on opioids and the overdose crisis that we've experienced and show some data on that. And then we're going to go into stigma reduction and non-stigmatizing language, which hopefully will sound somewhat familiar. It's often called recovery language. And we'll talk about why that is. And then we'll talk about evidence-based OUD treatments and some key takeaways. And like we said, we've got some really exciting research and different activities that we're thrilled to share with each of you today. And I have a warning here that we wanted to add, just because this can be very personal to a lot of us. Almost 100% said you work with clients, but a lot of us go into helping fields because we have a history of wanting to help people and our families and loved ones and friends. So this can hit home. So we recognize if you need to take a second, take a few deep breaths, and be sensitive to any experiences that you're having while we're discussing this as well, since we'll be talking about some sensitive topics. So many of you know that there's a lot of substances available in our society. Some of them require prescriptions, things like opioids always require a prescription. Others, like alcohol or nicotine, you can buy over the counter depending on your legal age. And others are just illegal under all circumstances. Things like heroin are not legal in the United States. And then often they cause a significant social problem. 22 million people in the US have reported using illegal substances within the last 30 days. And so that's a lot of people that we work with and family members of those people. And about 23% of them are in that 18 to 20-year-old range that we're talking about. So it's oftentimes not just in that age range. So when we're talking about it and you work with that group, that's just to keep that in mind. And substance use can cause things like temporary changes, that euphoric feeling, changing the way you're able to think, your emotions, the way that you feel, and behaviors that people might do otherwise. Maybe they wouldn't do that if they were using those substances. And yes, Chris just put in chat, thank you. If you have any questions as I'm talking, feel free to put those in chat. We might answer the questions along the way as we go, but we will periodically address them and make sure that we answer all of your questions today. And then, as you see on the screen, some of the long-term problems from substance use can include things like substance use disorder and relying excessively and chronically on that substance, which is then interfering clinically significantly in the person's daily functioning. And I will show a slide next to talk more about opioids specifically and those diagnostic criteria. And then things like dependence and having that physical dependence marked by tolerance and withdrawal from the substance. This is all substance use disorders in the DSM-5, now the DSM-5-TR, right? Another text revision. And then there are also health concerns and overdose and death that can be associated with substance use. Even someone using a substance for the very first time, which we've unfortunately seen in many states where a youth is trying marijuana or trying a cigarette for the first time, but there's fentanyl in that, and that can be very life-threatening. So this really impacts everybody. And this is chart for those of you who aren't in Utah. You can look at your own state there as well, but this is just drug overdose deaths by state, and this includes all substances, so not just opioids. And you can see the darker the color gets, the higher the rate of overdose deaths per 100,000 people. So there's some really cool statistical software that allows us to weight people, because some of these places that we live, right, like Carbon and Emery counties, we don't have 100,000 people that live here. And so they're able to weight it so that one person is equal to another person in a community of 100,000. So that's what you're seeing, that 6.9 to 11, right? That base category all the way up to 21 to 57 people per 100,000 people. And that just gives us an idea and a way to see things equally across our states and across our communities so that we can interpret the data accordingly, dependent on our population size, which when we're talking about rural areas is very important, because 5 overdoses, 10 overdoses in a rural area with 20,000 people is very different than 10 overdoses in a very populated area. And we want to know why, right? Why is that happening? So one of the most common substances that people are talking about and have been talking about are opioids. And a lot of you are familiar with this, given that we did that poll and almost everyone said yes. We're working with people or know people that have had opioid experience or their family members. Opioids are, for the purpose of our discussion, this is how we'll refer to them, a highly habit-forming class of chemicals that are used to reduce feelings and intensity of pain. They're often prescribed in acute pain treatment for things like surgeries, dental work, those types of things. And some common examples are things like oxycodone, codeine, morphine, Vicodin, fentanyl, and then heroin is also an opioid and has the same exact chemical composition in the brain. So it releases the same thing in the brain that you would experience with, say, a Percocet or a Vicodin. And interestingly, 80% of people who use heroin, so 4 out of 5, first misused or used a prescription other than prescribed. And so it is really high in that people are first using prescription medication and then transitioning to heroin, that illicit substance. And substance use disorders, including opioid use disorders, are treatable health conditions that involve that use of the substance that, again, we're focusing on clinically significant distress and social, occupational, and familial problems. And oftentimes, people who are using opioids, you can see this blue chart just to hit it home. This is from SAMHSA, that you can see the majority of people are using prescriptions that have an opioid use disorder. And then that small circle there are the people who also use heroin or heroin alone. So most of the people who are reporting this are using prescription painkillers. And that's why we're going to focus our efforts on talking about opioid use disorder more specifically than broad substance use disorder. So the remainder of what we're going to talk about today will focus on this criteria. And so this is taken straight out of the DSM-5. It should look pretty familiar with the different diagnostic criteria. And so if you're looking a problematic pattern of that use leading to clinically significant impairment, and then the people have to have 2 or more of these following criteria in the past year. And the first one being that opioids are often taken in larger amounts or over a longer duration of time than is intended. Number 2, there's a persistent desire or unsuccessful effort to cut down or control that use of the opioid. Number 3, there's a great deal of time spent obtaining, using, or recovering from the physical effects of the opioids themselves. Number 4, craving or a strong desire or urge to use their opioids. Number 5, recurrent opioid use resulting in a failure to fulfill major obligations, either work, school, or home obligations. 6, continued use despite persistent social and interpersonal problems due to the effects of the opioids or the effort to obtain opioids. Number 7, important social, occupational, or recreational activities are being given up or being reduced because of the opioids. 8, recurrent use in situations in which it could be physically hazardous. So driving, for example, while using opioids. Number 9, continued use despite physical and psychological problems, which is exacerbated by the opioids. And 10 and 11, 10 is talking about tolerance and 11 is talking about withdrawal. So tolerance is either a need for increased amounts or the diminished effect when somebody uses the same amount that they once used to achieve the same desired effect. And then number 11 with withdrawal, it is either opioid withdrawal or opioid or similar substance taken to relieve that withdrawal symptom. So we'll talk a little bit about that. And that's why, right, we're talking about prescriptions, but heroin is the same thing and will relieve those withdrawal symptoms. And that's that slippery slope that we talked about. And when we're talking about medical conditions in general, mental health disorders are a medical condition, and opioids are no different. There's actually quite a debate in the field of stigma reduction and substance use disorders talking about, well, are we still talking about these as medical disorders, right? Is that something that we still want to talk about? And in the sense that these are treatable and chronic mental health concerns and mental health conditions that respond to treatment. Yes, they are mental health disorders, right? It's in the DSM-5. We've been treating it, but we also know that it is chronic, recurring, and is not often a one-stop shop for treating substance use disorder, and opioids are no different. And so I think that's an important thing to talk about, is that there is a debate in the field of whether or not we should continue to call substance use disorder specifically because of some of the criminal and other components that often come with a substance use disorder. There's been a lot of criminalization and moralization of people having substance use disorders. And so we try to get away from talking about those things because they're often side effects of the substance use, and the treatment for substance use is so effective that we try to focus on that model of disease to talk about it. But I think there's a lot of interesting research, and we could talk forever on both sides of that argument. But for the purpose of stigma reduction, we've been trying a long time in the field to really focus the efforts of, this is a disease model, we can treat diseases and people can recover. And so that's been the primary focus, but there are arguments on the other side that I also wanted to mention that have some merit, right? Like, we don't want to remove personal responsibility from, and people can have different impacts and have their own self-determination. And we're going to talk about that all today as well. So that's a good segue into talking about some of the side effects of opioids that I mentioned in the previous slide. You can see there's a whole host of side effects from using opioid prescriptions as well as heroin. All the opioids will cause these different effects, and they range from cognitive dysfunction, sleep disorders, drowsiness, physical dependence and tolerance that we talked about, dry mouth, tooth decay, hyperalgesia, which is actually an increased experience of pain. So even though opioids are used to treat pain, oftentimes patients who have chronic or long-term pain have increased experiences of their pain while on opioids, which is so counterintuitive and so hard for people who are trying to treat their chronic pain, experiencing more and more pain, and then wanting more and more of that opioid to relieve the pain, right? So it's a very vicious cycle. Accidental overdose and death, breathing and heart problems, constipation and bowel dysfunction is a major one, low sex hormones and risk of fracture. And when we're talking about these health consequences, things like infections from injections are also common, skin or nose, HIV, sexual dysfunction, including reproductive function and irregular menses or periods in women, and newborn opioid dependence just due to that exposure. And I think those sclerosed or tract veins, right, can be there as well. The main thing on here is that 44 people, and this chart's actually a little old now, that I think it's a little higher, people in the US are overdosing from prescriptions specifically each day. And that's a lot of people that we're losing. And so to show a video, I really like this video because it demonstrates, and you all can see my video screen, right? Hopefully. Okay. It demonstrates some of the neurological components of an opioid and how that works in the brain. And so it's done really well. So I'm just going to play it and hope, and I'll mute myself so you can hear the screen from National Geographic. Oh, why am I not hearing? Oh, because, sorry. Now we can hear it.
This is Susan. Susan loves to bike. While out for a ride, she falls and breaks her arm. Special cells called neurons send a signal through the spinal cord to the brain, which interprets the signal as pain. Susan understands the pain means she needs to go to the hospital, and her body is equipped for survival, helping her not to panic so she can seek help. Many of her neurons are covered in proteins called opioid receptors. These receptors act like a brake to slow down the neuron's ability to send pain signals. When injured, her body releases natural painkillers called endorphins. Like a key in a lock, endorphins activate opioid receptors, slowing down the pain signal and preventing a panic. Susan gets treated for the broken bone, but 3 months later, her arm still hurts. And now that pain is making her feel depressed and anxious. So her doctor prescribes an opioid painkiller. There are many different opioids, but they all share a chemical similarity to our own endorphins. This allows them to bind to the same opioid receptors and stop pain signals. But that's not all they do. Deep inside Susan's brain is a region called the ventral tegmental area, or VTA for short. The VTA is full of neurons that produce a chemical called dopamine. When something good happens, dopamine is released, giving Susan a feeling of pleasure. This helps teach her brain to keep seeking out good things. To keep dopamine neurons in check, inhibitory neurons keep the brakes on until something good comes along. Just like the pain neuron, these neurons are covered in opioid receptors. When Susan takes the painkiller prescribed by her doctor, the opioid receptors turn off the inhibitory neurons and release the brake on the dopamine neurons. The rush of dopamine temporarily eliminates Susan's depression and anxiety, and she feels relief, calmness, and even euphoria. As Susan continues to take the painkillers, her brain responds by trying to regain its balance. Her inhibitory neurons work extra hard, even when the opioid receptors are activated, and it becomes harder and harder for her dopamine neurons to release dopamine. Susan finds that she needs to increase her dose of painkillers in order to feel comfortable. This is called tolerance. Eventually, Susan's pills run out. Inhibitory neurons that had been working overtime are let loose, clamping down on those dopamine neurons and shutting them off almost completely. Now, not only is Susan in pain, but the depression and anxiety come back. On top of that, Susan feels ravaged by an inescapable physical sickness far worse than any flu. Susan's body is going through withdrawal. Most people who take opioids for a long time tend to experience some withdrawal, but they can still stop taking the pills and return to normal. But for people like Susan, it's not so easy. Her genetics and the environment she grew up in put her at a higher risk for addiction. Her withdrawal symptoms aren't just unpleasant, they're unbearable. Susan thinks the only way to feel normal is to find more opioids. And this is how the cycle of opioid addiction emerges, driven by a brain trying to regain its balance. But there is hope for Susan. Though the road to recovery can be challenging and there may be setbacks, treatment can retrain Susan's brain. With the help of medication and therapy, Susan finds pleasure in her life once again.
All right. I don't know how many of you have seen that video before, but I really enjoy how it explains how your brain is working on opioids. And I think they did such a lovely job with that demonstration of seeing those neurotransmitters going. And so the opioid crisis that we talk about as the opioid overdose crisis has really grown over the past several years. This really is our second wave of the opioid overdose crisis. The first one was way back when we were first learning about opioids and prescribing them, and people thought they were safe. Come to find out they're not. And that's because we have so many people losing their lives to them. About 1.6 million people experiencing OUD in 2019, and only 1 in 10, 12% of people who need substance use disorder treatment actually received it in 2019. And so there's a really big gap in people getting the services that they need to treat very treatable substance use disorders. And oftentimes that's because of stigma that is keeping people from getting that help. And that leads to then continued deaths from overdose, over 841,000. And in recent years, that's actually two times as likely. More people are dying from overdose deaths than car accidents. And so that's really wild and disheartening to hear that people are losing their lives twice as often to substance overdose. And about 71,000 overdose deaths in 2019, with 185 per day. And over 2/3 of those are opioid related. And that just continues to increase, them being opioid related versus, just any other substance by itself. And so here you can see, again, talking about prescription opioids in this pie chart. On the left side of my screen, there's the blue slice where people are getting prescriptions from their doctors, and that's about 35%. But the other side, the large gray slice that is over 50% of people are either being given medications or are taking them from friends or relatives. And so I think it's key that when we're talking about opioid use disorder and people misusing or using other than prescribed pain relievers, a lot of times people have the best of intentions, right? Oh, I have this leftover medication from my dental surgery or my back surgery. You can have it. Sounds like you're in pain. It is that very slippery slope. And so making sure you're getting those medications out of your house and not giving them to anybody that is not prescribed them. And also teaching our patients that, and parents and caregivers and people who have a lot of opioids in the home, anybody with chronic pain. So making sure that those are locked up. And so just to highlight that, right, over 50%. And specifically, when we're talking about opioid overdose deaths, one key component is fentanyl. And you've probably heard about fentanyl. And it's a very powerful synthetic opioid approved by the FDA. And it is, again, used for pain reduction, right? Analgesic and anesthetic, and it's very effective. And 82% actually of overdose deaths have fentanyl in them, which is that synthetic opioid. It's 80 to 100 times stronger than morphine, which is why it then leads to higher rates of death and may require multiple doses of naloxone, which we're going to talk about, which is a temporary overdose reversal medication. And then fentanyl has a new analog, which is probably something we're going to start hearing about, carfentanil, which is actually 10 1,000 times stronger than morphine. And so this is really, really risky because of some of the examples I gave earlier about people who might not know fentanyl is in their substance of choice, or using substances as prescribed, right, and thinking they're buying a pill off the street that is a specific pill that they need, but is laced with fentanyl or something else much stronger. So just keeping that in mind as we're going and looking at this chart to see those fentanyl related deaths. That's that top blue line. And I don't know if you can see my mouse, but it's this one. Okay, right here, other than methadone, that primarily fentanyl is really leading the way in overdose and substance related overdose deaths. And then way down here is psychostimulants and cocaine and stimulants. I think is going to, we're seeing a trend upward. So I think that's going to be where a lot of our efforts start to go based on the trends throughout the United States. So as we're talking, you can think about that as well. Prescriptions closely behind: heroin, benzodiazepines, anxiety medications, and antidepressants. So that's something really important to think about while we're talking about fentanyl, just being that way above the rest, right? So these other substances are also a problem, but fentanyl really is leading. And this is all substance related overdoses that have opioid deaths. And so you can see that as it gets darker again, there's more opioid related deaths as that color gets darker. And a lot of our states, you can see going over, getting higher in those ranges. And then here's opioid overdose specifically, and why we have such a focus on it here in the Midwest region, all of the surrounding areas, where have a lot of our deaths related to opioids, just to hit that home. In Utah, this is a chart that I wish we had more recent one. If anybody finds it, let me know. I'd love it. But despite my efforts to find a new one, an updated one, this is what we have, and it's still pretty accurate. So looking back at 1999, everything's pretty blue, cool blue. And then as we go further, you can see different places getting orange and red and darkening over time, particularly Carbon and Emery County that are red first and continue to stay red, but other parts of the state joining as well, and parts of the southern state. A lot of these parts that are darker are more rural areas. And so that's worth noting as well when we're looking at that per 100,000 population statistic here for Utah. And I don't have it for Arizona, but talking about the rurality and the opioid crisis in our rural areas is really important, because about a quarter of people actually live in rural areas or non-metropolitan areas, and there are fewer resources, there's less hospitals, there's more stigma. The rate of overdose is actually higher in rural areas because it's further to get to support services. And oftentimes you might not want to go because, right, everybody knows everybody, and that stigma with overdose can be really high. And that rate just continues to increase. And we've talked about these other things, but just really focusing on the fact that rural areas might have different needs than urban areas when we're talking about intervention, therapy, and doing different things to reduce that overdose death rate. And pass it to Chris.
Yeah. All right. So we're about halfway through our time here, and I know it's been us talking a lot to you. So we have a poll for you here, asking, how much of this information presented today did you already know about the state of opioid use, opioid use disorder, and associated death? So this is just more information for Ashley and I to know what you already know. And just, we are coming up to a couple of things. We're going to do a short break when this poll is over. And then after this, it gets highly participatory. So prepare yourselves. There's going to be multiple breakout groups and discussions happening. So maybe you'll want to be in a place where you can talk to colleagues. So we'll give this just one more minute here to respond. What I'm seeing on my end is a majority, or most often, Ashley, people are saying that they knew a little of it. So that's great. We're sharing new information today. So I'm going to go ahead and close it out so you all can see it on your side. But as you can see, You know, definitely more along the line of either I knew a little of it, which was about 60% of our participants today, and 30% knew I knew most of it. So I'm glad at least 60% of you were getting you some really new information of what Ashley talked about. So we're going to go ahead and do a 2-minute stretch break. So I'll start my timer and you're going to get 2 minutes, and we're going to do a little bit of a longer break in a little bit. So we're halfway through our time together almost. And again, like I said, after our stretch break, there's some more, we're doing a little more blah, blah, blahing at you, but then we're switching to doing mainly discussions. So be ready for that. So I'm going to start my timer. All right, Ashley, if you want to get us going again.
Yes, thank you. Everybody come back to your computer. Hopefully you had a chance to do some stretching, use the restroom, and make it back to learn some more great information. We're going to shift now our focus to talk a little bit more about stigma. And this little word cloud actually came from a group of professionals doing a poll everywhere, where we asked, what's the first thing that comes to mind when you hear the word stigma? And all of these words are things, the larger they are, right, the more often people said them. So things that really stood out in this group were things like judgment, prejudice, and that being really associated with negative things, biases, expectations, misconceptions, and just a really nice, I think, list that captures what people think of when they hear the word stigma. And that's correct, right? They're just generally defined as negative beliefs or attitudes towards a group of people, and they can often include public policies directed at that group of people. And generally, there's 3 main categories of stigma that are social stigma, structural stigma, and self-stigma, all of which really just reduce a person from a whole person to a tainted or discounted one. And I just think that quote is so powerful, and that's what it really does, is stigmatize people in that way. Social stigma really focuses on groups of boosting those stereotypes of stigmatized people. Structural stigma is that negative attitude or behavior that represent larger groups. Things like not being able to find a job would go into that. And then self-stigma is when the person internalizes these negative beliefs and turns them towards themselves and really starts to feel the effects of that towards their self-concept. And stigma increases harm for people. It can cause things like fear, prejudice, discrimination against those groups. It reduces quality of our healthcare for those individuals and can lead to negative effects on their self-esteem, their hope, their view of the future, reduces rates of recovery, and is really a destructive cycle in that we have that public stigma that then really leads to discrimination, prejudice, fear, damages that person's self-esteem, their self-concept, hope. They might avoid treatment, which internalizes that stigma to self-stigma, leads to shame and self-doubt, and reduces rates of that recovery, or they drop out of treatment. And then they use the substance potentially to avoid or suppress negative effects. And then it just goes right back into that negative cycle. So we can see how that happens for people trying to get into recovery, trying to get into treatment. I'm pass to Chris to talk a little about this.
Yeah, so I wanted to make sure, as we're thinking about stigma reduction and the stigma that our clients experience in practice or in the community or coming in for clinical services, that we're really thinking about self-determination and how we can apply that into our lives, both as a practitioner and then also just as a community member, right? So our self-determination and social work ethics really say, that it's the rights and needs of clients to be free to make their own decisions. And so how this applies to stigma reduction in our practice and our life is we really want to empower our clients to use the words they prefer to self-describe their lived experience using substances. And so, for instance, it's really in the academic research world and the practice world of like substance use disorder and things like that. We don't use the word addict anymore. We try to stay away from addiction, things like that. However, when our clients choose to use those words, we want to empower them to use the words that they want to use to describe their own experience. However, as a clinician, I just want to encourage you to avoid using harmful and stigmatizing phrases, even if your client uses that, because we can model good, I don't want to say good behavior, but we can model for them, like, give yourself some grace. Like, how do we help them see, like, you're in recovery, or other words they can use that are more positive to really reduce some self-stigmatizing language and make sure that we're creating really safe places for them to come. Because in some research that Ashley and I have done, people talk about, like, the words people use are so harmful, and that it makes a space I don't want to go back to. I don't feel supported. So really trying to model that good behavior of, I want you to choose the words you want to use, but I also want to use these words that are more maybe empowering and, are really give you some, I don't know, like, kudos for you're doing a lot. So I think just be mindful of that when you're doing your practice.
That is said so great, Chris, and leads right into what we're going to talk about with stigma reduction and how we all play a role in that, especially people who are providing that frontline service and being our treatment providers and therapy providers. And one of the main things for reducing stigma reduction is being educated, but also education by itself is not enough. So just throwing fact sheets and information at people is not enough. We need real life stories and real information, real connection with people. In our helping fields, I think that's a little easier to understand than other people who have more of those traditional fields that are not as hands-on with people who hear their stories over and over again. And hearing those positive stories is just as important, because it can get so hard over and over again to have the same thing happen. I think, Chris, your example at the very beginning, when it is just so, it just stands out so much in the helping field that we do the same thing over and over again. It's like batting your head on a wall. And so making sure that you have those positive stories that go along with that, and that can really help improve our attitudes as well as the general public. And again, using that non-stigmatizing or recovery language, which really is just person first language, and putting the person first when we're talking about them. Things like acceptance and commitment therapy groups and job training can help reduce stigma, particularly self-stigma for people who have internalized that shame and that experience. That counseling and vocational training can really help encourage and support their recovery. And then strategies of empathy and compassion, I think, are so important, because people do often identify that the way that they are talked to or talked about are just so unempathetic and just devoid of compassion. And changing our narrative and helping them to change their narrative and see themselves in a more positive light and a empowering light can be so important, to just lead with acceptance, mindfulness, and awareness of our own language.
And Ashley, we just got a question. It was a private one to me, so you won't be able to see it, but I think it's really fitting for what you're talking about right now. So the comment in question is, I attended an AA group, so that helps, with that context, as part of a class. And I noticed that every person who introduced themselves used the term like addict. So for instance, my name is blank and I'm an addict. How would you go about working through this?
I think that's a really good question. Alcoholics Anonymous is that's how a lot of people introduce themselves, same as Narcotics Anonymous and other groups. Some of them that I've seen transitioning towards is, and I'm a person in recovery, right? Is once that person feels that they are in recovery, is that can be empowering to them to change that narrative. But I think also it's okay for people to have that as their identifier as well, if that's meaningful to them. And Chris, I can see you have something to add.
Well, and recently, so this summer we had our opioid summit that was in Vernal, Utah, and we had a lot of local agencies participate. And this really came up too. So I think this is a really valid thing where, in social work, we're having these conversations about language and self-determination, but not everyone is coming from the social work field. And so we would have this whole group, it was a men's group. And, they were all about tough love and like, you deserve this pain and you deserve this to like go through these struggles, and someone doesn't forgive you, well, that's your own fault. And just lots of that really just punitive way. And so one way we thought about this was, I'm a social worker, so I, stick to my ethics and values very firmly. And so I just try to model good behavior, and with the counselor there, trying to have some really open discussions about, I get that's your model and I respect that model. Just let you know, these are just some changes in the field that's happening, and making sure and trying to provide education around the practitioners that maybe aren't. But AA is a systemic example. AA has used that terminology for just ever. And so how do you create that systemic change? And some of that's modeling good behavior. And also, again, just going back to, well, if that whole group of men want to self-identify that way, I want to, not diminish that for them, but also let them know that like not everything has to be punitive, right? Because I think that's another thing with substance use disorder, and even being in a recovery, like constant punishment, and I deserved it. And it's like, but do you have to? Is that really how we want to treat people? So there's no real direct answer, I think, for that, but I do think that we just as social work as a profession can model that for folks. So.
I think that's a great addition. And I know sometimes modeling it can be uncomfortable. And so I acknowledge and I see you for modeling, and sometimes modeling in difficult situations like with law enforcement or with people who have this repertoire of terminology that they've used forever. And just continuing to model that's really important in all of the different disciplines that work with people with substance use disorder to become more compassionate. Yeah, less punitive. So one thing that we can model, which leads greatly, I love that question because it does lead perfectly into this. And talking about how we speak and how we express our compassion and what we say is what matters, right? So some common stigmatizing replacements that we can use that will help improve our person first or recovery based language that are non-stigmatizing are moving from things like Chris already said this one, right? Away from addict or addiction or dirty and towards the actual diagnostic term, which is a person with substance use disorder. So in the DSM, there is not substance abuse disorder in there. It is substance use disorder, right? So we're just helping educate people with that. Former addict, getting clean, right? That implies that the person is dirty. So talking about a person in recovery or a person who is substance free, clean or sober. I already said this one. It's like my neurological pathways have been formed to say it this way. And treatment is the goal versus treatment is one path to recovery, or this is the only treatment that works. You have to pull yourself up by your bootstraps and you have to go cold turkey, right? I've heard that one so many times. Cold turkey, you have to pull yourself up. And that is such a ingrained version of things that people have, especially in rural areas. That's common of, well, I did it this way, you have to do it this way. But acknowledging that there are many, many pathways to recovery is really important. And then opioid replacement or opioid management, talking more about medication-assisted treatment for opioid use disorder, because that is key in changing that language slightly because it is so effective. And then relapse, we would change to recurrence or return to substance use. And I think that's just so important these are just a few examples. There are many more for recovery language and person-first language that you can also look for.
Yeah, and Ashley, I'm a little worried about time. I'm wondering if we just want to skip this first discussion and go to the next discussion.
I think that works.
Because we only have 30 minutes left and it takes 10 minutes to read the other Savannah story.
Yeah, let's skip. I love it. Let's keep going. All right. Yes. And I'm going to just talk briefly about evidence-based treatment. Our last group, really, we asked people to introduce themselves in our breakout activity, but you've already kind of done that in the chat. So if you haven't done it, you are welcome to introduce yourself. Some evidence-based treatment methodologies, really what we're talking about is focusing on the whole person, the biological component of people, psychological and social components of people. And in this chart, you can see some of the things that contribute to each of these biopsychosocial type things. And what I want to stress in this slide is that treatment works, it's effective, and recovery is possible. And a whole person approach is most effective. So if you're getting MAT, having counseling or therapy kind of is the gold standard and is required in the state of Utah. So some cognitive behavioral therapy focusing on thoughts, behaviors, and experiences and changing those or learning new coping skills is key. Motivational interviewing, non-judgmental interviews, and guidance in that direction. There's a lot of really great MI workshops. If you've never had an MI workshop, it might be a really great opportunity to learn a new way of interacting with your clientele. And next is mindfulness-based stress reduction, which focuses on mindfulness and awareness and can be a really powerful tool when talking about cravings and substance use reduction. And then lastly, acceptance and commitment therapy, which is really values-based and mindfulness-based and focusing on what a person values and why they are choosing to remain substance-free or what is motivating them. And this is just a nutshell as well. There's a lot more information on these evidence-based treatments, but I wanted to give you just a taste of some of those examples. And then focusing again on rural areas, there's a lot of initiatives out there to reduce the deaths that we're experiencing and improve quality of care and increase our services and really things for low income residents as well. Naloxone is really key, and making sure that all of our patients and clients who are using opioids as prescribed or even not as prescribed have naloxone on hand or a family member. Reducing the barriers to MAT for OUD, like methadone, naltrexone, and buprenorphine, which are all FDA regulated and approved, and then enhancing our telehealth services, insurance strategies. And I know I don't have to talk to you all about parity for behavioral and mental health, but advocating for that and focusing our enrollment efforts on people who are at risk. So screenings, things like SBIRT are really important if you're familiar with that. And I'm going to pass it to Chris.
All right, so sorry that we had to skip our other discussion, but I really wanted to make sure to get to this one. This is something we're very excited to launch. And the previous discussion was supposed to be about stigma, and this will as well. So we're going to give you 10 minutes to read. I'm going to put the link into the chat right now. So what we have here is, as part of a grant I am the PI on, we have developed comic books that chronicle the lives of people's stories of drug use and into recovery in Utah. And so this one is really a special, I mean, they're all special stories that we have. We have 5 in total. This one is Savannah Ely, and so she's actually from Price, Utah. So some of you might actually know her and have heard Savannah talk about her incredible story. So this is actually her novelized version of her story. And so I really, if you can, we'll stop talking in a second, but click on the link. It will take you to a box link. Let me know if you are not able to view it. Skip the pre-writing, just go right to the comic, because it's actually meant to be used actually for book groups at libraries to combat stigma in communities, just with the general population. But we're going to talk about it more specifically for social workers. But go ahead and read Savannah's story and just be aware. It's very graphic. This is her story. This is how Savannah wanted to tell it. It was made using a participatory model. So everything in here is what Savannah wanted to share about her story. There's a suicide trigger warning, drug use, child removal. There's a lot of trauma in this story. So if that is something you prefer to skip, we understand, or you can just read parts of it because you'll see the triggering pieces. But I do encourage you to read it because it's just, you know, when we have print versions of these that are starting to circulate, and Savannah got her story. I was there and she was just so excited to see the paper version of the story. She's so excited to share with people to really inspire them to not only to combat stigma, but also just to show that like recovery is possible, to be in a state of recovery. So with that, I'll stop talking. We'll give you 10 minutes. So at 1:12, we'll come back together, and then we're going to break you off into breakout groups. So 1:12. And if you are having any problems with the box link, please let me know. All right, y'all. So hopefully you have read most of it, all of it. If you, sorry if you didn't get to read the entire thing before we break you out here. So Ashley, you want to go to the next slide? So we're going to break y'all up into groups of 5. There's going to be just some guiding questions we've given you that you can talk about with your group. But I do want to encourage you to feel free to have your discussion go in the direction that you would like it to go, especially around stigma and social work practice. We'll put these in the chat once you're in your breakout rooms. But really, we want to know, we want you to discuss what surprised you or stood out about Savannah's story. What did you notice about stigma in this story, which was very prominent in Savannah's story? As a social worker, what steps would you have taken to support Savannah in treatment and recovery? And then really, what are your key takeaways? What are the things? I mean, there's so many things with Savannah's story that will always stay with me, but what are the things you were really like, ooh, you know, that's going to resonate with you and you're going to think about in your social work practice? So with that, Teresa, if you want to break out, folks, we're going to bring you back in 10 minutes. And because we're so short on time, I apologize. We're not going to be able to really have a process of the discussions because we're going to have to kind of close out since we're ending at 1:30. So Teresa, if you can break everybody out once you're in your rooms, we'll put the questions into the chat for you.
All right, I see people trickling in. Welcome back, everyone. I think your breakout rooms probably kicked you out. We hope that you had a good discussion. We're going to keep talking about some keys that probably came up when you were talking in your groups. Some of the things that we wanted to make sure were left with you today and that you had to take with you in your practice, in your personal lives, are these key things that you can do today, starting now, right? So we can all start with a focus on prevention and increasing those protective factors and reducing risk factors, things like disposing of medication in our houses, locking it up. We can also focus and share what we've learned about harm reduction, reducing undesirable consequences, and helping make a pathway for recovery, which was mentioned in Savannah's story, and things like naloxone for opioid overdose reversal. And before we go on, we wanted to do a quick poll and ask if you have been trained on how to administer naloxone or Narcan, brand name. So you should see that poll pop up. On whether or not you've been trained on administering naloxone. Most people have responded. All right, I'm gonna go ahead and share results. All of us have control. We're sharing them multiple times. Most of you said no, but about 30% said yes, you've been trained on how to administer naloxone or Narcan. So I think that's great. It actually segues nicely into talking about naloxone a little bit more for those of you who have not been trained, which temporarily reverses opioid overdose. And a few signs of overdose are small pinpoint pupils, a faint heartbeat, blue fingernails, can't be woken, slow or shallow breathing, gurgling, choking noises. The key here is to call 911, and then you can get free naloxone and get trained throughout Utah. There's a few websites on your screen if you want to take a picture, but UtahNaloxone.org provides free naloxone to everyone, and there's a good list of naloxone distributors at naloxone.utah.gov if you want to go there to find it. The other things that we want to send with you today are focusing on treatment and recovery. There's no one-stop shop. And then share, including what you learned in Savannah's story. Just don't be afraid to get out there and share. Here's some resources for you all that are national. But we have several here in Utah too that are more specific. And we want to say thank you for all of your time. I know Teresa has some announcements and we wanted to save time for questions or feedback on that story process.
Yeah, so Teresa, if you want to go, then we can just stay on. I know we're going to be past time, y'all. So if you need to hop off when Teresa's done, that's fine. If not, we can definitely hang around and chat.
Yes, thank you, Ashley and Chris, for this presentation today. Just as a reminder, before you log off, ensure that your name on Zoom matches the name that we can identify through the registration so that we can send you your certificate. You will also be getting a feedback survey about the presentation, and within that, you can also request topics for the future. Your certificates, if you have earned credits, will come early next week. And this is the last CEU we're presenting for this year, but they will start up again in January. So be on the lookout for those. And like Chris and Ashley said, if you do have questions and want to hang out on the Zoom call, feel free to stay on and we will get that taken care of. And hopefully you all have a great rest of your day and a great rest of the year.